Welcome to this explainer on Cauda equina syndrome. We're unpacking a rare, high-stakes medical emergency where literally every single hour dictates a patient's lifelong outcome. This isn't just your standard back pain. No, this is a true neurosurgical emergency. It requires incredibly rapid recognition and intervention to prevent permanent life-altering disability.
All right, here's our roadmap for today. First, we'll look at the anatomy of the horse's tail. Second, the neuroischemic cascade. Third, recognizing those crucial red flags. Fourth, the race against time. And finally, we'll discuss the long road to recovery. Let's get right into it.
Starting with Section 1, Anatomy of the Horse's Tail.
So, we have to ask the fundamental question that really kickstarts this whole medical mystery. What exactly happens when the literal horse's tail in your spine gets pinched? Well, to answer that, we've got to look at what this structure actually is, and more importantly, what it controls.
The term Cauda equina literally translates from Latin to horse's tail. It refers to this absolutely critical bundle of lumbosacral nerve roots. These roots descend inside the dural sac right after the spinal cord itself terminates. Now, it's pretty fascinating. Even though these roots are located centrally in your spine, they actually function as peripheral nerves. They span all the way from the L2 to the S5 segments, and they're responsible for sending motor and sensory signals to your lower limbs. Plus, and this is absolutely crucial, they provide parasympathetic innervation to your bladder, bowel, and pelvic organs. It's basically the main control cable for the lower half of your body.
But here's the paradox. This syndrome is incredibly rare. We're talking about it affecting only 1 to 3 people per 100,000 annually. It accounts for fewer than 2% of all lumbar disc herniations. Yet, despite this extreme rarity, it generates a disproportionately massive number of medical legal claims in spinal practice. Why? Well, the reason is simple, really. The consequences of missing it are just completely catastrophic.
Moving on to Section 2, the neuroischemic cascade.
Roughly half of all Cauda equina cases, so about 45 to 55%, are actually caused by a massive central lumbar disc herniation compressing the spinal canal. This most often happens right at the L4, L5, or L5, S1 levels. The other half? That's made up of various pathologies like tumors, infections, trauma, or severe degenerative stenosis. But here's the thing. No matter the underlying cause, that resulting mechanical compression is exactly what starts the biological timer ticking.
Think of nerve root compression kind of like a kinked garden hose. The physical pinch restricts both the flow of electrical signals and vital blood nourishment. First, that mechanical compression deforms the nerves. This immediately impairs the microcirculation, causing venous congestion and arterial insufficiency. Essentially, the nerves are starved of oxygen, a state we call ischemia. And without energy, the mitochondria just fail. This triggers severe inflammation, the release of really damaging cytokines, and ultimately axonal injury and demyelination. The nerves literally begin to break down.
Which brings us to Section 3, Recognizing the Red Flags.
When evaluating this, we're looking for the classic triad. That's bladder or bowel disturbance, reduced sensation in the perineal or saddle area, basically the areas of your body that would literally touch a saddle if you were riding a horse, and sexual dysfunction. Now, these are often accompanied by bilateral sciatica and lower limb weakness. It's so important to remember that if a patient experiences any of these symptoms, even if they're just partial or transient, it means multiple nerve roots are in profound distress.
This leads us to the most critical fork in the road for any patient presenting with these symptoms. You have to ask, why is timing the single most important factor in Cauda equina syndrome?
Well, the answer lies in prognostic classification. There's a stark contrast between CESI, which is incomplete Cauda equina syndrome, and CESR, which is Cauda equina syndrome with retention. In CESI, the patient actually still has preserved bladder sensation and some voluntary control, even if their voiding is altered. But if that cascade progresses to CESR, the patient experiences painless urinary retention and a complete loss of bladder sensation. This distinction strongly dictates the severity of a patient's long-term medical outcome. Catching the patient in that incomplete phase, that is absolutely the primary goal.
That takes us right into Section 4, the race against time. The very first hurdle in this race is obtaining an immediate MRI. It's the undisputed gold standard diagnostic tool here, no question. An MRI provides direct visualization of the neural compression. It confirms the mechanical block and allows surgical teams to immediately plan for an urgent, highly targeted decompression surgery.
And this timeline shows exactly why doctors move so fast. Both experimental and clinical data suggest that irreversible neuronal injury can start in just 6 to 12 hours of compression. Because of this terrifying speed, optimal surgical decompression within 24 hours is the ultimate target. This is especially true for patients in that incomplete CESI phase we just discussed because it provides the best chance of saving bladder function. Now, the 48-hour mark is heavily debated as the outer limit for improved outcomes, but honestly, the reality is simple. The sooner the pressure is relieved, the better the odds are of neurological preservation.
Finally, Section 5, the long road to recovery. The really sobering reality of this condition is that while patients often regain strength in their legs, autonomic functions just have incredibly poor recovery rates. In fact, satisfactory continence is achieved in only 30 to 50% of patients, and that's even when surgery is performed early. The ischemic damage to those highly sensitive nerve roots just leaves a lasting mark.
Because of this lasting damage, patients require a massive, multidisciplinary rehabilitation effort. This isn't just about physical healing, it's about rebuilding an entire life. Care spans from intensive physiotherapy and urological management to specialized bowel programs and sexual counseling. Furthermore, the psychological toll is just immense. Cognitive behavioral therapy, or CBT, plays a really critical role in helping patients cope with the depression and anxiety that so frequently follows such a dramatic neurological event. But modern science refuses to accept that 30 to 50% recovery rate as the final word. Researchers are aggressively looking for emerging adjunctive therapies to actually protect and regenerate these nerves, going way beyond just unpinching them mechanically in surgery. We're seeing some incredible investigational work into stem cell approaches, delivering neurotrophic growth factors directly to the nerves, using functional electrical stimulation, and even pharmacological neuroprotection. Things like using antioxidants, such as N-acetylcysteine, to halt that destructive inflammatory cascade we explored earlier.
So I want to leave you with this provocative final thought to ponder as we conclude our explainer today. As artificial intelligence accelerates our ability to diagnose these subtle red flags faster, and as these neuroprotective therapies evolve to literally shield our nerves from ischemic death, can we eventually close the window on irreversible nerve damage entirely? It's definitely a race against the clock today, but perhaps tomorrow, science will give us more time. Thanks so much for joining me on this deep dive into Cauda equina syndrome.